by our resident, Dr. Saurabh Garg, and would be moderated by our faculty, Dr. Dharmendra. So I would request Dr. Saurabh Garg to please go ahead with his presentation.
Good morning, everyone. My presentation is on vesico-ureteric reflex. I'm starting.
See that. Yes, go ahead. Start.
So first, I would like to discuss about the incidence. Male to female prevalence of vesico-ureteric reflex is 3:1, and about at 0 to 6 months of age, but shifts to 1:1 by 24 months of age. Younger the child with UTI, greater is the likelihood of discovering reflux. VUR is relatively rare in children of African descent. Now, this table demonstrates the age-specific incidence. So, at less than 2 years, there is a 38% incidence of VUR. It decreases as the age progresses. Like 2 to 6 age group has only 26%, and 12 to 21 years old people have only 7.6% of incidence of VUR. Younger the child with UTI, greater is the likelihood of discovering the reflex. Now, there are some genes involved with the pathophysiology of VUR. There is a complex polygenetic mechanism which regulates it. So, some of the genes that are involved are BAX2 on chromosome 10q, GDNF and RET receptor, angiotensin receptor 2, then ACE. Any genetic misregulation of the ureteric budding can lead to the Caput syndrome also, that is congenital anomalies of the kidney and urinary tract. Now, discussing the embryology of vesico-ureteric reflux, it is at early reaching of ureteric bud to the urogenital sinus due to early budding and over-rotation. There will be high and lateral insertion of ureter and inadequate incorporation and insufficient intramural length of the ureter in bladder. That will lead to VUR plus minus any renal anomalies such as malformation, dysplasia, hypoplasia, or agenesis. Now, I will be discussing about the functional anatomy of the anti-reflux mechanism. So, there are 3 factors responsible. First is the functional integrity of ureter. It acts as a dynamic conduit with neuromuscular antegrade propulsion of urine from the kidney through ureter to bladder. So, second is anatomical composition of VUJ. So, it is due to the intramural portion of ureter. And also, at the extravesical bladder hiatus, forms a Waldeyer sheath which contributes to the formation of deep trigone. So, Paquin once suggested that approximately 5:1 ratio of tunnel length of ureteral diameter in non-refluxing junctions is important, and in refluxing VUGs, the ratio was 1.4:1. Third factor is neuromuscular coordination between UVJ and UV. So, types of VUR. So there are 2 types, primary and secondary. Primary is due to the deficiency in the function of the UVJ anti-reflux mechanism that we just discussed. Secondary reflux is caused by abnormalities of UVJ and bladder dysfunction of a congenital acquired or behavioral nature. So anatomical causes constitute posterior urethral wall, urethrocoel collapsing into bladder lumen, bladder neck, distal obstruction like stricture or mass. Now, neurofunctional causes include neurogenic bladder, that may be due to occulta, spinal dystrophism, sacral dimple, hairy patch, or diminished rectal tone will be there. Overactive bladder, detrusor sphincter dyssynergia. Now, UTI and VUR are also associated to each other. Reflux is not a general cause of UTI. Infection-related cystitis, bladder irritability and dysuria, upsetting voiding pattern, these are the symptoms associated with it. And reflux facilitates pyelonephritis. That is important. Now there is an international classification of vesico-ureteric reflux. So grade 1 is only the ureter is not dilated, reflux is there in ureter. Grade 2 is reflux is up to the pelvis and calyces, but still dilatation is not there. In grade 3, mild to moderate dilatation of ureter and renal pelvis and calyces with minimal blunting of the fornices. Grade 4 is moderate ureteral tortuosity and dilatation of the pelvis and calyces. Grade 5 is gross dilatation of the ureter, pelvis and calyces and loss of papillary impressions and ureteral tortuosity. So these are the diagrammatic representation. Now, at presentation, the patient may be asymptomatic. It may be a cause of follow-up case of antenatal hydronephrosis, pyelonephritis, UTI, renal dysmorphism, obstructive features in case of secondary VUR. Patient may be presenting with CKD. Now, diagnosis and evaluation. First, we'll do the assessment of lower urinary tract. Imaging will be there. USG findings of hydronephrosis, developmental anomalies, febrile UTI. These are the indications. Indirect and direct. So, indirect contrast enters the bladder indirectly after excretory urography. It is non-invasive and false positive as contrast may remain in ureter and pelvis after filtration. Now, in direct cystographic imaging, we do avoiding cystourethrogram, that is the gold standard to diagnose VUR. It may be helped by radionuclide cystogram, ultrasonography also, with color Doppler or eco-enhanced contrast agent. Now, VCUG, it provides both functional dynamics and structural anatomy. In staging images, we can see the UV contour, we can see the diverticulars, urethrocy, reflux rate, and configuration and blunting of the calyces in the staging images of VCUG. In dynamic images, we can see the passive and active reflux in filling and voiding phase respectively, bladder neck anatomy, funneling, delayed post-void films to rule out any concomitant PUJO. Cystography during UTI should be avoided. Radionuclide cystogram, approximately 1% of the radiation exposure is generated by VCUG. It is ideal for surgical follow-up as a screening modality. It uses technetium-99 per technate. Greater sensitivity in grade 2 to grade 5 reflux is there. Its disadvantage is that it has poor anatomical details. Now, ultrasonic cystography. These days, it is also used. Modern transducers are coupled with eco-enhancing contrast agent. So it is contrast-enhanced USG that is used. Radiation exposure is not there, so it's the benefit of this. Now, cystoscopy can be done. Modern management of reflux does not include routine cystoscopy. It really adds to the diagnosis. Useful before open surgery to confirm the uteric orifice position and duplication, proximity of diverticula to orifice, and to clarify urethral patency. Now we have to, after assessing lower tract, we have to assess the upper tract. So USG, it's the mainstay of renal imaging in VUR. It is helpful to monitor the renal growth and status over time, guides further evaluation. Perfusion abnormality can be detected by resistive index measurement on color Doppler USG, and it can be correlated with high-grade reflux, pyelonephritis, and scintigraphy findings. Reasonable minimum evaluation in any child with UTI, we have to use USG. Now, we can also follow top-down approach. So clinically relevant reflux with potential to cause renal injury need to be diagnosed. VUR in the absence of scintigraphic renal abnormality is unlikely to cause further renal damage. Only a DMSA scan is obtained after a febrile UTI. Children with a negative DMSA undergo no further evaluation unless they develop recurrent UTI, in which case a VCUG should be obtained. Now, this is a chart, febrile UTI, then we have to follow up with DMSA scan. If it is positive, then we have to do VCUG, and if not, then no further evaluation. Now, these are EAU guidelines of 2021, in which it is a strong recommendation that in infants with febrile UTI, we have to use renal and bladder ultrasound to exclude obstruction of the upper and lower urinary tract. Also, in all infants, we have to exclude VUR after the first episode of febrile UTI using voiding cystourethography or a DMSA scan first. In case of a positive DMSA scan, follow up with VCUG. And also in boys more than 1 year of age, exclude VUR after the second febrile UTI. Now, a pregnancy can be associated with VUR because physiologically bladder tone decreases due to edema and hyperemia and predisposing to bacteriuria and higher urine volumes, slower drainage, and high risk of pyelonephritis is there in pregnancy. They are prone for preeclampsia, UTI, fetal loss. So correction of reflux before pregnancy is recommended. Now resolution by grade is, grade 1 and 2 reflux resolve usually 80%, but grade 4 and 5 usually resolve only 9 to 25% of the cases. Now principles of management. Spontaneous resolution of reflux is very common and facilitated by the correction of bladder bowel dysfunction, BBD. Higher grades of reflux are less likely to resolve spontaneously, especially when diagnosed in older children after UTI. So sterile reflux is unlikely to cause any significant renal damage. Prevention of UTI is more important than VUR resolution. The use of prophylactic antibiotics is safe and beneficial, particularly in the high-risk group. There is a role of medical management in most forms of reflux. So the classical approaches offer daily dose, low dose of prophylactic antibiotic to suppress infection. Then every case of reflux should be offered time to resolve spontaneously, despite its grade. In the newborn patients, it is reasonable to wait until approximately 5 years of age because we know that it resolves spontaneously also. After this age group, boys with asymptomatic reflux will require little or no formal follow-up. If the reflux fails to resolve even after 5 years of age, girls should undergo surgical correction only on the premise that it will reduce the maternal and fetal morbidity during a future pregnancy. Now, in the medical management, we use different antibiotics. Like in children less than 2 months, we give trimethoprim, amoxicillin. After 2 months, antibiotic of choice is trimethoprim, sulfamethoxazole, and other drug most commonly used is nitrofurantoin. There are some landmark studies regarding VUR. I have mentioned some of them: Birmingham reflex study, international reflex study in children, Swedish reflex study, and randomized intervention of the management of VUR. Now, some guidelines. I'll be discussing a few. So there's a strong recommendation that we have to offer immediate parenteral antibiotic treatment for febrile breakthrough infections. There's a strong recommendation that initially manage all children presenting at the age of 1 to 5 years conservatively. Offer close surveillance without antibiotic prophylaxis to children presenting with low grades of VUR, and ensure a detailed investigation in the presence of LUTS is done, especially in children after toilet training. If LUTS is found, the initial treatment should be done for the lower urinary tract symptoms. Now I'm discussing some management. Surgical management indications are breakthrough UTI, failure of medical management, refluxic ureter opening into bladder diverticulum, progressive renal scarring, and urethral obstruction associated with VUR. Now, relative indications are presence of massive reflux, grade 4 to 5, reflux associated with periurethral diverticulum in girls whose reflux persists even they have after reached full somatic growth, and parental preference. Endoscopic treatment is sting technique and HIT, hydrodistension implantation technique. So in sting technique, we have to inject the material. I will be discussing what material to be injected, and that material is to be injected under the intramural urethral mucosa. So we have to visualize ureteric orifice. We have to put the material submucosally just below the ureteric orifice. So appearance of the mound after completion of the injection will be there, and there will be slit-like ureteric orifice will be visible as shown in the diagram. Now, second technique is a double hydrodistension implantation technique. So in this, first we'll bladder empty, ureteric orifice is visualized, followed by hydrodistension. So the ureteric orifice is clearly visualized in second picture. And after that, we have to do the proximal HIT is then performed with needle inserted into the mid-ureteral tunnel at 6 o'clock position. So we have to inject the material inside the ureteric tunnel, whereas in sting surgery, we are injecting the material below the ureteric orifice in the bladder submucosally. So this is how they've injected the material, and this is how the mound is created, and a slit-like ureteric orifice is left. So it leads to now we have to do follow-up. Follow-up in the child is maintained on antibiotics for 3 months, and early USG is done. Follow-up USG is done after 3 months. If VUI still persists, 1 or 2 repeat injections can be considered. And if still there's no resolution, then minimal invasive surgery is recommended. Materials used for endoscopic correction is polytetrafluoroethylene paste, Teflon paste, and then second is polydimethylsiloxane, PDS, macroplastic. The third is dextronomur and hyaluronic acid, that is also part under the trade name of Deflux. Then fourth is polyacrylate polyalcohol copolymer, PPC. Now the success rate of endoscopic treatment is 80 to 90%, whereas open surgery is 98%. It's less invasive, it can be done as a take care procedure. Those are the benefits. Now, surgical principles are: we have to exclude the causes of secondary VUR first, and then adequate mobilization of distal ureter without tension and damage to its blood supply. Then we have to create a submucosal tunnel that is generous in caliber and should satisfy the ratio 5:1. Then attention should be directed towards preventing angulation, stenosis, twisting of the ureter. Attention to the muscular backing of ureter to achieve an effective anti-reflux mechanism. And we have to gentle handling of the bladder to reduce post-operative hematuria and bladder spasm. These are the surgical principles. Now, there are few open surgical techniques. There are intravesical procedures and extravesical. So first we will be discussing intravesical Qualitino lead butter technique. Its principle is to bring the ureter in through a new hiatus superiorly to the original insertion. A submucosal tunnel is created in the direction of trigone medial to the ureteric orifice. So, diagrammatically, we'll be discussing. In the first case, we have given horizontal incision, then we give a vertical incision on the bladder, and after that, we have to see the refluxing ureteric orifice and cannulate it with the feeding tube. After that, the ureter is now mobilized into the bladder, and the superior lip of the hiatus is retracted to sweep up the peritoneal attachments. After this, a new hiatus is created and suture is passed from new to original hiatus extravesically. Now, using the suture as a guide, the ureter is pulled through the new hiatus. A submucosal tunnel is created from the new hiatus to the original hiatus, and the original hiatus is closed. Then the ureter is pulled through the tunnel, and the mucosa is sutured circumferentially to the bladder mucosa in the new position. So these are the diagrammatic representations of how ureter is brought through the new hiatus. Now the second technique is the Glenn-Anderson technique. Ureter is mobilized intravesically. The submucosal tunnel is created infrahiatally in the direction of the bladder neck. So its advantage is the course of the reimplanted ureter is less liable for angulation and kinking. But the limitation here is that as we are directing it towards the bladder neck, so the length of the tunnel is limited by the distance to the bladder neck. Success rate is 98%. Now, there is third technique, Cohen's cross-diagonal technique. It's most common intravesical procedure with a success rate of more than 98%, especially suited for small, thick-walled trabeculated bladders. And it is done when concomitant bladder neck reconstruction is planned. So, but the problem with it is that difficult retrograde catheterization of ureter in the future. With diagram explaining in right ureteric orifice is open, the ureter is mobilized, and in the B picture, it is seen that the right ureteric orifice is implanted medially and above the left ureteric orifice after the submucosal tunnel is made. Now, we can do a bilateral reimplantation also. The more superior ureter is tunneled transversely with its new orifice just above the contralateral orifice, and the other ureter is tunneled inferiorly with the new orifice located inferiorly to the contralateral hiatus. Now, I will be discussing Lech-Briguier technique. It is an extravesical procedure. Advantage is that bladder is not opened up. Thus, postoperative hematuria, bladder spasm, these things are minimized. The technique is simple to learn. The main concern is the development of transient voiding insufficiency that is seen in up to 20% cases. So the technique is, we have to cut the operated umbilical vessels and ureters identified. Along the course of ureter, the plant tunnel of 5 cm is marked. Now, detrozotomy is done and detrozal flaps are created. The ureter is placed in the detrozotomy and the flaps are closed over it. Now we can do the same procedure robotically also. Now there is a comparison between the various surgical techniques. So I have discussed the intravesical techniques, 3 intravesical techniques and Lech-Briguier technique are there. So the advantages of intravesical techniques is that in Qualitino lead butter, long tunnel can be created. It is valuable in higher grades of reflux. But problem with lead butter Qualitino is that reimplanted ureter are more liable to twisting and kinking. In Glenn-Anderson technique, it is intravesical and infrahiatal. So the course of the implanted ureter is less liable for kinking, but at the same time, the length of the tunnel is limited. In Cohen's cross-diagonal, it is useful in small and thick-walled bladder and also with concomitant bladder neck reconstruction is considered. In Lech-Briguier, it is a good thing because extravesical it is done, so post-op hematuria and bladder spasm are less. But disadvantages, transient voiding insufficiency may be there. Post-op evaluation can be done by USG at 6 to 12 weeks post-op. BCUG can be done in selected cases. In pre-op high-grade reflux, but patient having persistent hydronephrosis in UTI beyond 3 months, a patient having voiding dysfunction, family anxiety. Now guidelines are there. I'll be discussing strong suggestions. So we have to offer open surgical corrections to patients with persistent high-grade reflux and endoscopic correction for lower grades of reflux. This is a strong recommendation. And second, we have to offer surgical correction if parents prefer definitive surgery to conservative management. That is also a strong recommendation. So complications of ureteric implantations. is the early complications include persistent reflux or contralateral reflux. It is seen in 5 to 11% cases attributed to distortion of contralateral hemitrigon as a result of pop-off mechanism or missed contralateral VUR on initial cystogram. The management is observation or prophylactic antibiotics. Obstruction may be there. Early obstruction is due to twisting or kinking of the ureter, intramural clots, blood clots, then extramural compression by submucosal hematoma or edema at the site of anastomosis. Now, the long-term complications. Long-term complications can be due to obstruction, can lead to obstruction, and it could be due to ischemia of the distal ureter, angulation of the ureter in its entry to the bladder, and underdeveloped submucosal tunnel, stenosis of the neo-ureteral orifice. And its management can be done by balloon dilatation and stenting, unroofing of the distal few millimeters of the tunnel ureter to relieve the obstruction while maintaining the anti-reflux mechanism. If these interventions fail, reimplantation is indicated. A recurrent or persistent reflux can be there. Most failures are caused either by high-grade reflux or as inadequate ratio of tunnel length to ureteral diameter is there. Ideally, it should be 5:1. Another significant cause of persistent or recurrent reflux is failure to recognize secondary reflux. In most situations, improving bladder storage or emptying with a combination of anticholinergic agent and intermittent self-catheterization results in spontaneous resolution of secondary VUR. Thank you.
Thank you, Saurabh. So we would take comments from our experts. Do we have Dr. Chandra with us, or Dr. Ansari, or Dr. Bhatt? Would you like to give any comments, or any of you? Is Dr. Chandra with us, Dr. Ansari, and Dr. Bhatt? So in the meantime, I would request our residents to have their queries ready if you want to have some query or kind of comments to be made, or any of the faculty who is joining us. They are most welcome to give their comments. Mr. Nimesh, am I audible?
Yes, sir.
Okay. So do we have those experts with us?
No, sir. Only. But
Okay, fine. So
Hello.
what I will do is, yes. So
Hello.
what I yes, Dr. Bhatt, please go ahead.
Yeah. Let me compliment and congratulate the resident who has covered the overview of this one. There are few of the points which has to be taken care in the sense that in management of VU reflux, the missed part is BBD. So one has to be very careful about this when we are evaluating the patient, to treat the BBD and then treat the VU reflux. Second point is that most of the time we need a conservative team. More approaches towards conservative, the indications or surgery are limited. And the one should not rush too much of getting the MCU. MCU is good enough to diagnose, and the indication both he has taken up nicely, top up and bottom approach. So now people go for a top up approach more, get the non-invasive test first, and when indicated, go for VU. And the deflux is coming up nowadays more, and especially in higher grade where you want to buy time, that is the deflux is give the treatment, and many patients it is curative.
Right.
Thank you.
Thank you, Dr. Bhatt, for your comments and the points nicely made about the bladder bowel dysfunction. So bladder bowel dysfunction is very important when you take the history in patients of VUR. So if the patient is associated with bladder bowel dysfunction, then definitely the chance of urinary tract infections are more, the chance of resolution of UR becomes less, and then other kind of even the failure to surgical treatment again becomes more if there is associated bladder bowel dysfunction. So always treat the bladder bowel dysfunction, and the treatment would include giving laxative to the patients, giving some kind of behavioral therapy, timed voiding. All these are very important when you manage bladder bowel dysfunction in these patients. The other point about the endoscopic injection, definitely yes. Again, the indications would be in the milder degree of reflux when you want to buy time, or sometimes when the patients cannot be put on prophylactic antibiotics, or they have some adverse effects due to the antibiotics and you want to wait for the resolution, then endoscopic treatment would probably be the first treatment. Yes. Do we have other experts for comments? Otherwise, what I will do is I will summarize the whole thing, and then we will take up a few MCQs for the residents. So we all know vesico-ureteric reflux is a very controversial topic, right? Starting from its pathology and how it affects the children. Because again, the premise that the bacterial infection which goes into the kidney causes damage to the kidney in a patient who doesn't have UTI is again very controversial, debatable. So again, the treatment and the of the vesico-ureteric reflux would depend upon a lot of factors and the expertise that you have, and the decision that the experts make in a particular patient. So we all know there's an incidence of around 1% vesico-ureteric reflux in children. Then it could be primary vesico-ureteric reflux or secondary. Primary is usually congenital because of the short intramural ureter, and the secondary is due to the raised intra-abdominal pressure because of the distal obstruction, which can cause vesico-ureteric reflux. The presentation could be either prenatal or postnatal. Prenatally, we have seen around 15 to 20% patients of antenatal hydronephrosis. Antenatal would be actually a case of vesico-ureteric reflux. And then they should be evaluated in the form that postnatally, if there is associated ureter or bladder abnormalities, then we should do micturating cystourethrogram to confirm vesico-ureteric reflux. And if they have bilateral hydronephrosis, again, they should be done with BMCU to rule out vesico-ureteric reflux. Postnatally, these patients usually will present with febrile urinary tract infection. So post-febrile UTI infection, usually if patients have are subjected to this MCU, then around 25 to 30% cases may be of vesico-ureteric reflux. So usually, when would you evaluate these cases of postnatal febrile UTI? It is said that usually if there's two or more than two urinary tract infections, you should go ahead and evaluate for presence of vesico-ureteric reflux. Or if there is only one febrile UTI, but with associated anomalies, or through breakthrough infection, or if they are associated with bladder bowel dysfunction, all these probably only after first febrile UTI, you can go ahead and do MCU. Then we come to the grading of vesico-ureteric reflux. We all know there are 5 grades, 1, 2, 3, 4, 5. First and 2 are milder. Third and fourth could be said as moderate, and fifth is severe, or sometimes fourth and fifth could be considered as severe form of vesico-ureteric reflux. But again, there is some variability, some confusion, like between 2 and 3 and 4 and 5. So you have to be very careful about how to diagnose and grade them. The other thing is they have come up with is the ureteral diameter ratio, which probably is more better than grading them. So ureteral diameter ratio is the distal ureter diameter is measured in comparison to the vertebral length. between L1 to L3. So lower border of L1 to upper border of L3 is measured, and you measure the distal ureteral diameter. And the ratio is considered as to be having a prognostic factor. And the third thing that they have come up with is the vesico-ureteric reflex index. So VUR index, which depends upon the grading, the sex, and the associated bladder bowel dysfunction, and the timing of reflux. So that index probably helps you to take the decision how to treat these patients. All right. And there are other urinary markers also they have come up with for vesico-ureteric reflux, that is procalcitonin, CRP. Then there is a metalloprotein, matrix metalloproteinase, or urinary mRNA level. So all these are experimental, and they have trying to see that whether they can be used as a biomarker for vesico-ureteric reflux. About evaluation, he has discussed about the top-down approach and down-top approach. And management, it can vary from watchful waiting, in particularly milder reflux, and giving prompt treatment once there is a urinary tract infection. It again could be antibiotic prophylaxis in patients who are more prone to have recurrent urinary tract infection. And then the management could be either surgical in the form of endoscopic management, or open surgery, or by even lab or robotic surgery. So endoscopic surgery, as I said, there could be various techniques. The sting technique, where the deflux is put just below the ureteric orifice, and the hit technique, where it is put inside the intramural ureter. And it's a double hit technique where you have combined the two. So these are the various techniques by which you can put endoscopic injection. And usually these are given in patients with milder reflux and those patients who cannot be put on antibiotic prophylaxis. Surgical management, again, the two techniques measure, intravesical and extravesical technique. Intravesical, the basic principle is Politano-Ledbetter, and the modified variety is the Glenn Anderson variety and the Cohen's variety that he has described. And the extravesical technique is the Lich-Gregoire technique. Right. So Lich-Gregoire technique, all have their advantages and disadvantages. He has discussed it. Extravesical, the major disadvantage, the patient may have post-operative retention, particularly when they are done on both the sides. And it is very important in these patients to follow up these patients by routine urine routine examination, if necessary, urine culture, and by ultrasound imaging. When we talk about the imaging, in the follow-up imaging, usually we need not do a MCU for follow-up. We can do a scintigram, renal CT scan, to know whether the reflux is resolving or not, or even a contrast-enhanced ultrasound. There are various other imaging studies like MRI is also being done, but still not clinically used. And there is a thing called thermal imaging, where the bladder urine is heated, and then they try to see whether the vesico-ureteric reflux is resolving or not. So these two are probably coming up, and they are still not in clinical practice. This was in brief the summary. I would request our experts, if they have come in, Dr. Bhatt would like to give some comments, and if we have Dr. Yes, Dr. Bhatt, go ahead.
Yes, there are two important points more which needed. You see, when we are going for a reimplant, and especially the high-grade reflux, and if the ureter is tortuous, then that tortuosity is to be cleared. Another point is that two dilated ureters, there has to be some tail ring of the ureter. And while taking tail ring, take care that there is no damage to the blood supply. And the tail ring is done on the lateral side. Medially, there is a blood supply of the ureter. So these 2 points are to be added to your water.
Right. Thank you. Thank you. Very important. Grossly dilated tortuous ureter may require tailoring, and it should be done laterally to avoid the blood vessels. And we have to make a tunnel in the ratio of 5:1, at least 3:1, and we should try to achieve 5:1 ratio so that the reflux mechanism happens. And I think the kinking should not happen. That is the most common complication after doing a surgical management of reflux is obstruction, which is even worse than having vesico-aortic reflux. So you have to be very careful while doing the surgical treatment of vesico-aortic reflux. Can we go ahead with the case? So we'll go ahead with the MCQs. What is the accepted ratio of tunnel length to ureteral diameter found in most normal children without reflux? Pardon? A, 5:1. So agrees everybody? Right. What is the accepted ratio of tunnel length to ureteral diameter found in most normal children? Achha, okay, so 4:1. That was the answer? So, okay, fine, that's fine. So signs or symptoms of bladder dysfunction include dribbling, urgency, incontinence, curtsying behavior in girls, all of the above. Pardon? All of the above, because all these symptoms like dribbling, urgency, incontinence can be there. Even the curtsying behavior in girls. Do you know what is curtsying behavior? What is that? Vincent's curtsy. What is that?
Child sits on the and
presses the perineum to stop, to prevent incontinence. So this usually is done by the girls, and this is called curtsying. Right. So treatment of bladder dysfunction and detrusor overactivity, regardless of its severity or cause, is directed at dampening the overactive detrusor contraction, dilating the urethral sphincter, lowering the intravesical pressure. A and C, all of the above. A and C. Okay, good. So we need to dampen the overactive detrusor contraction and lower the intravesical pressure. Yes. There is a strong association between presence of reflux in patients with neuropathic bladder and intravesical pressures of greater than 40 centimeters. Yes. Bladder infections and their accompanying inflammation can also cause reflux by lessening compliance, elevating intravesical pressure, distorting and weakening the UV junction, all of the above, none of the above. Yes? All of the above. It decreases compliance, it creates a poor compliance, elevating intravesical pressure, because bladder infection sometimes can cause what? Some bladder neck inflammation and all that. So that can cause an increase in pressure and the distorting and weakening of the UVJ junction. Yes, I think that's the most important, distorting and weakening the UV junction due to infection. The toxins liberated by bacteria will result in that distortion and cause a kind of a functional shortening of the intramural length, which results in vesico-aortic reflux. Which of the following is true regarding the presence of fever? It represents eventual renal scarring. It correlates with greater than 10 to the power 5 bacterial colony forming units. It may not always be a reliable sign of upper urinary tract involvement. It increases the likelihood of discovering VUR, C and D. C and D. Okay. Why? So it may not be a reliable sign always of upper urinary tract involvement. Fever can happen without involvement of upper urinary tract, and it increases the definitely. A febrile UTI will definitely increase the likelihood of discovering VUR. What is the best study for the detection of pyelonephritis and cortical renal scarring? DTPA, DMSA, MAG3, CT, renal ultrasound. DMSA. So, though ultrasound can tell you something about the irregularity in the contour of the ultrasound, sometimes there will be cortical decrease in the cortical tissue there, renal parenchyma also, which can be detected on ultrasound. But DMSA definitely is much superior to ultrasound in detecting the scarring. And right, so that is DMSA. Early postoperative obstruction can occur after a ureteral reimplantation due to edema, subtrigonal bleeding, a twist or angulation of the ureter, blood clots, all of the above. All of the above. Yes, so the early postoperative complication. So it's an early obstruction which occurs due to edema, subtrigonal bleeding, twist, angulation. This is very important. Angulation and twist, particularly in cases of Glenn Anderson, right? And blood clots. All these are important. But if you put a stent, do you think these would cause obstruction? Clots or edema? I'm not very sure. Why should they cause if there is a stent? Angulation definitely can cause some degree, even if there is a stent, right? Anyway, so I think the answer is all of the above. Yes. So that was the end. Right. So again, anybody who has any query? Anybody? Yes, go ahead, please.
But sir said that we should tailor the ureter from the lateral side. But actually, we do not follow this.
No, see, so you have to know the exact, the question was, Dr. Bhatt, that why should you tailor on the lateral side? But you, in the operation theater, we do not care exactly whether it is lateral or medial, or once you have transected the ureter or removed the ureter, it's very difficult to know whether this is lateral or medial. So ideally, you should label it the lateral or medial side, ideally. But usually, when you are seeing the ureter, you can identify the vessels, whether they are lying on which side, medial, lateral, or whichever side. So try to avoid the vessels. That is the main principle. Dr. Bhatt, any comment on that?
Yeah, I think you see we can identify medial and lateral. Once we mobilize the ureter and we put that one, then there is you apply the with the marker, or you apply the web copes on the medial side, sparing the lateral one, and vessels usually blood supply to the ureteral is from the medial side of that one. That is the region of this one. But as far as the basic principle is that you preserve the, you see, long-term complication, if you see, is the ischemia of the ureter and then narrowing. So to prevent that one, when you are doing, or if you don't tailor, then there will be recurrence of reflux. So prevent the recurrence of the reflux as well as long-term complication of ischemia also.
Right.
Dr. Shivam, Dr. Shivam, hi. Dr. Ansari.
Yes, oh, great. So, Dr. Ansari, you are welcome. We have Dr.
Somehow
my
video will not be seen because it is not working.
Yes. Okay, fine. You can just go ahead with your comments.
Yes, sir. See, this is a very common question, and throughout our long practice also. And as you rightly said, the blood supply of the ureter comes from three sources. One is from the submucosal route, second is the subserosal route, third is from this iliac vessels. So when we dismantle this ureter, this iliac vessel business is gone. So the blood, when the ureter is hanging in the air, it is dependent on two sources. One is submucosal, subserosal. Now it is the decision of the surgeon whether he wants to cut it from medial or lateral side. See, the simple logic I will not prefer to cut it which is facing the surgeon's face. Because if any suture goes away, or there is small this hole in the mucosa, that will create a uretrovesical fistula. Although this will not be detected, but this will be a common cause of persistent reflux. So it is always good. See, simple rule is the wall or the margin which goes towards the back of the base of the bladder, opposite to the surgeon's face. So the suture line will fall away from the surgeon. So the intact line will be anterior. So that the chances of fistula will be less. Because many a time there are small holes in the mucosa whenever we are creating this the subdetrusor tunnel, submucosal tunnel. So that is also very safe. Once this matter is materialized that the external iliac or internal iliac has been dismantled, now it is the blood supply submucosal serosal. Then it is better to cut when it goes back on the base of the bladder. That area is safer.
Right. So very good point, because once you have to mobilize the ureter, you are devascularizing the ureter. The iliac vessel branches are definitely devascularized. So the major blood vessel that the supply is through the the adventitial or the submucosal, And it is a good thing that when you are doing intravesically, then the suture line should be behind so that the two suture lines of the bladder and the ureter do not overlap.
Yes.
So to prevent the formation of uretrovesical fistula. It's very good point. And when you do on the extravesical side, it would be the other way around. So extravesical, the suture line should be inside so that again the extravesical bladder suture and the ureteral suture do not overlap. So very good point. Yes. Anything else you want to comment on vesicular reflex, Dr. Ansari?
So everything was going because this is a very vast topic.
Yes.
So far,
That-
because I joined little late, so I do not know what went in the beginning, sir.
Now, we went through the whole topic, and
Okay.
as we know that this is a controversial topic, even the pathogenesis and whether how VOR causes damage to the kidney again is a controversy. The theories are changing every time. So, yeah. So, I would ask you in your practice, how often do you do endoscopic injection, and which are your indications?
So we frequently do endoscope injection. We do in primary reflux. We do in the secondary reflux. We also do in the failed reflux also in all three categories we are doing.
Okay, so which patients do you take? I think you don't take patients with severe reflux. You take probably the milder and the moderate degree of
Yes,
VOR.
yes.
Yes.
Usually we take our nearly 90% cases are up to grade 3.
Grade 2 only.
Grade
Yes.
3,
So,
grade 3,
grade 3.
Yes.
Okay, 90% are grade 3.
90% are from grade 1 to grade 3.
Grade 3. Okay. So again, the question is usually the grade 1 and 2 will resolve, and usually the prophylaxis or watchful waiting is the treatment of choice. Why
Yes.
do you want to put in injections in these patients?
No, it is not. We never put it just in the beginning, even in grade 3.
Okay.
It is always
So-
the surveillance is the first
Okay.
this policy. When they fail, then only.
Then on.
Even if it is a grade 3. In grade and 4, we discuss with the parents that with time 4 and 5, there are very hardly 20 to 10 to 30% of chances of resolution. If they want an immediate solution, then we may try. Otherwise,
Okay.
as far as this spontaneous resolution is concerned, the chances are very low.
Right. What do you think about the long-term results of endoscopic injection?
Endoscopic results, yes. Short-term results is 85%. Cumulative results from grade 1 to grade 3. Short-term result, 85%.
No, long-term results.
Yes, I'm
After
telling you
suppose 1
first.
year. After
Yes,
1 year, how
PG,
many would
yes,
recur?
PG should first know the short-term result 85, and long-term results when beyond 2 years, it is there is a drop of 15% because of the displacement of the implant. 15%. If I am saying this 85%, then it will come to 70%. So 15% of the
Okay.
kids, 15% of the kids may redevelop reflux. Although in your although they belong to the successful category, but 15% will have this recurrence of the reflux.
Right. So do you give a second injection in these patients who have recurrence?
See, if it is there may be two conditions. It may be grade 3 or grade 1 and 2. Grade 1 and 2 can be kept under observation. And you will be surprised, even if the reflux fails, nearly 20% of the kids, their recurrent UTI, pyelonephritis, that usually resolves. I do not have any explanation to this. So, Hannah, we should not hurry to go to put another implant. So, it is better to follow them. If there is no UTI, there is no pyelonephritis, better to observe. Only the grade 3 is after discussion with the families. Even if they are settling, they are settled on ultrasonography, their kidney size is not increasing, grade of nephrosis is not increasing, pyelonephritis is not occurring, then even failed cases can also be kept under observation. If it is a male boy, yes.
Right.
If it is a male child, yes. In female, yes, you have to intervene.
So if male child, usually you would not intervene if after 5 years of age, even
Yes,
if the
after 5
reflux is
years, absolutely.
right. girls usually you would do, right?
Yeah, girls, you see, in girls, grade 1 and grade 2 can be kept under close monitoring.
Kept as such.
Yes, 3 and above, they should be re-intervened. Yes.
Okay. Right. So amongst the surgical management, which is your preferred technique?
So I may be little biased for this. I basically practice coherence intravesical, whether it is unilateral or bilateral.
Okay. So either so you do robotically or by open?
We do robotically. 90% whenever we are needing this cohen, 90% this case this does going by robotic intravesical.
Okay. So robotically, intravesically.
Yes, yes.
Okay. Right. Okay. So you open up the bladder and do as we do in the open, you do it robotically, right?
Yes, yes. Putting
Yeah.
all 3 ports into the bladder and
Right. So thank you, Dr. Ansari, for your
Thank you.
those wise comments.
Thank you so
Doctor,
much.
I would so if nobody has any question, none of the faculty or residents, I would request our moderator to just wind up and then we will close the session, please. Dr.
Yes, sir.
Sumit.
So it should be followed by high tea, sir.
Oh, sure. So we are having it. You can have it online.
Oh,
please.
thank you. Thank you so much, sir.
Thank you.
Thank you.
Dr. Samir, please.
Thank you, Saurabh, for nicely covered that topic. And thank you, Shivam sir, for summarizing the topic very well, and all things are already covered. And thank you, our expert, Dr. Ansari sir and Dr. Bhatt, for their expert comment. And thank you, all faculty member and resident who might join us on the Zoom or in the seminar room. Thank you.
Thank you, everybody. And special thanks to our experts, Dr. Ansari and Dr. Bhatt. Thank you very much.
Thank you so much. Thank you so much, sir.
Thank you.
Thank you.
So have a good day.
Okay.